Hi guys, in this video we will talk about embryology, teratology, torch. Teratology studies congenital anomalies, their causes and treatments. These abnormalities can result from infection, torch, physical, metabolic or chemical conditions, and are passed from mother to child. Infections during the first trimester of pregnancy usually cause the most serious defects.
Hello, my name is Martina and now I'm going to talk about development. In addition to passing horizontally from person to person, touch infections can also transmit vertically from mother to infant. When a pregnant woman becomes infected, the infection can spread to the unborn fetus. Generally, the earlier the exposure to the teratogen, the more deleterious its effects. Infections during the first trimester are likely to cause more severe version of the congenital defect in the growing embryo. The later in the pregnancy than the infection occurs, the more likely that the fetus will develop a neonatal infection rather than develop a congenital abnormality. Now I'm going to talk about cellular. Transmission of the viral or bacterial agent from the mother to the fetus is often transplacental, but the means by which these particles can cross the placenta and affect the fetus is not fully understood.
Transmission mechanisms. Viral or bacterial agents cross the placenta, affecting the fetus. Rubella, RNA virus that is transmitted by aerosol and transplacentarily. Toxoplasmosis, parasite transmitted through cat feces or contaminated meat. And CMV, it can be transmitted through the placenta or direct contact during the children's breast for breastfeeding. Herpes simplex introducing risks the parental of transmissions.
Now we're going to talk about testing. First, toxoplasmosis is diagnosed by testing the Toxoplasma gondii parasite via PCR, microscopy, or inoculation, or identifying specific IgG, IgM, or IgA antibodies. Brain imaging like calcifications, hydrocephalia, microcephalia, and retinal exams assess symptoms, severity, but are not diagnostic. Congenital varicella syndrome is diagnosed through mother's chickenpox history during pregnancy, presence of dermatomal skin lesions in the infant, or detection of BCB, DNA, amniotic fluid, or fetal blood. Congenital syphilis is diagnosed via serology combined with clinical symptoms. Diagnosis is often presumptive, requiring follow-up for at-risk infants. Congenital parvovirus B19 is confirmed by PCR to isolate virus in the amniotic fluid or fetal blood, or by IgM serology. Congenital rubella is diagnosed isolating the virus via PCR or culture, detecting RNA through reverse transcriptase PCR, or identifying rubella-specific IgM and IgG antibodies. Congenital cytomegalovirus is diagnosed using real-time PCR or urine or saliva samples, or CMV-specific IgM, IgG serology in pregnant women. Widespread of screening remains limited. Congenital herpes simplex virus or HSV is detected by culture or PCR, with PCR being more accurate. Screening for antibodies is less reliable due to the lack of specificity or prevalence of oral HSV1 infections, which pose less risk than genital HSV2. Torch panel testing, a combined test for IgM or rising IgG antibodies in fetal, cord, or infant blood to identify congenital infections caused by toxoplasmosis, rubella, CMV, HSV, or BCV. It's a practical collective approach for neonates suspects of this infection.
Chickenpox. At road rate, it causes congenital varicella syndrome, skin lesions, lip hypoplasia, neurological anomalies with a mortality of 13% in the first month. Rubella. Infections in the first trimester has the highest risk of causing congenital rubella syndrome, which includes defense characters, heart defects, central nervous system denegate, and hepatosplenomegaly. Up to 85% of the babies born to infected mothers in the first trimester develop CRAs.
Cytomegalovirus or CMV prevalence affects 60% of adults in the US and is the leading cause of infection-induced birth defects. Congenital CMV occurs in 1 in 150 live births globally, and it is the primary cause of non-genetic congenital hearing loss. Clinical manifestations. Symptoms include petechia, jaundice, hepatosplenomegaly, chlororetinitis, and neurological manifestations such as physical and mental retardation and deafness. 7 to 10% of the infected infants show clinical signs, while many asymptomatic infants may develop symptoms later in life. Treatment. Symptomatic infants are treated with valganciclovir for 6 months, while asymptomatic infants typically don't receive treatment. Herpes simplex virus or HSV prevalence or SHV1 is prevalent in 50 to 70% of people in developed countries and nearly 100% in developing countries. Genital HSV2 affects 10 to 40% of the population, with 22% of pregnant women infected. Neonatal HSV. Ultra rare, neonatal herpes can be severe, causing viral sepsis, organ failure, encephalitis, vesicular rash, seizures, volume fontanelle, and death. Treatment. Acyclovir is used for affected infants, requiring prompt administration for optimal protection. And prevention. Cesarean deliveries are recommended when HSV infection is suspected, as 85% of neonatal HSV infections occur peripartum.